All right, so we talked last time about the different pressures. Which pressure is always negative? Intrapleural pressure, right? And why is it always negative? Okay, lymphatic vessels are always draining the space. Yeah, very good. The stretching, the pull. We have the rib cage pulling outward and the elasticity of the lung tissue pulling inward. So that stretches the volume of that space, which will decrease the pressure. So those are the major two reasons why we see a negative pleural pressure. So when is intrapleural pressure the most negative? At the end of inhale, end of exhale, in between breaths. End of inhale, right, at maximum inhale, it's the most negative. And we can see that in this graph. Pleural pressure drops here at the end of inhale, when our volume of breath in the lungs is at its peak. And then, but it always remains negative. So at resting, it's -4. At maximum inhale, it's at -6. Okay, and we talked about the different pressures and volumes in the lungs. We did that chart on page 542 of your handout. So now we're going to continue on with some other factors affecting lung inflation and lung deflation, inhale and exhale. So airway resistance. So how well we can move air in and out of our alveoli depends on a couple factors. Airway resistance is one of them. If I have asthma, how would that affect airway resistance? Would it go up or down? Up. I would have more resistance to airflow, wouldn't I, if I had narrower bronchioles? Definitely. So asthma is going to increase airway resistance, and what is that going to do to pulmonary ventilation? Increase or decrease it? Decrease it, because I have narrower vessels, I can't get that air into those alveoli. So think of some of these things. Asthma is something that would increase airway resistance. Alveolar surface tension, which way does that pull on the lung, on the alveoli? Inward or outward? It wants it to collapse, right? The water molecules that line the inside of that alveoli are attracted to each other and they want the lungs to collapse. So that's going to affect ventilation. If I have high alveolar surface tension, that will reduce pulmonary ventilation. Would you agree with that? What do our alveolar cells, our type 2 alveolar cells, secrete to overcome that inward force? Surfactant. So that's going to overcome that. And lung compliance, think about what the term compliance means. Think of someone who's non-compliant. If I say, hey, come with me, what does a compliant person do? Goes with it, right? With that person. Non-compliant does not move with it. So when we talk about the lungs being compliant, think about it following the chest wall. If I breathe inward, I increase the volume of my thorax by my external intercostals contracting and my diaphragm contracting and moving downward. So the whole space, the ribs move outward. If the parietal pleura and the visceral pleura are connected via that pleural fluid, the lungs should go with the chest cavity. Would you agree with that? So that's called compliance, the ability of the lungs to move with the chest wall. So think of it that way. If compliance means the lung is going with the chest wall during breathing. So it's, what type of force is it? Is it a force acting outward or inward on the lung? What? Outward, outward. So if I have, this darn pop-up always does this. If I have emphysema, I have blown out alveoli, what happens to the size of the lungs? Do they decrease or increase? Remember the barrel chest? They increase. So does the lung become more or less compliant if I have emphysema? They're bigger. They're going out with the chest wall. So they're more compliant. And that's kind of tricky because we think about we think about these forces on the lungs and disease reduces that. Well, not always. Emphysema is an example of increased compliance, which means the lungs are going to go with the body wall much more easily because they're full of these big air pockets. What have we lost? What does an emphysema lung not have? Of these three, what's lost? The surface tension is lost because there's no alveoli to have a water layer to attract itself, right? Because alveoli are blown out. Like I said, emphysema is like taking a sponge and taking your fingers and pinching out a big chunk of sponge. You just removed all those little air holes. So there's nothing to hold water. right? There's nothing to exchange air in an emphysema lung. Okay, so airway resistance then. Obviously, the flow of air at a given pressure change is inversely proportional to the resistance. So if I have a low resistance to air, if I have dilated bronchioles, I'm going to have a high flow. Would you agree with that? A pressure change is what's going to cause a flow, right? Pressure changes is going to cause a flow. So if I have dilated bronchioles, I just took my albuterol, am I going to have more airflow into those alveoli? Yeah. Now, if I have a reactive airway from exercise or cats, or sometimes people get it with beer, sometimes get it with a food allergy, I have increased resistance, I'm going to have a decrease in flow. Okay, so they're inversely proportional. Resistance then, in a normal lung, like right now, and nobody has an asthma attack going on right now, we can say that we don't really worry about airway resistance because we don't have a lot of obstruction to flow. We have cartilage holding our tracheas open. We have cartilage holding our bronchi open. And what holds our bronchioles open? Smooth muscle. And those are really tiny. And our alveoli and our alveolar ducts are really tiny. Why don't we see, with the tiny, tiny little airways, why don't we see a big increase in resistance? What do you think? What's one way to overcome that? There's so many of them, yeah. We have so many bronchioles and so many alveoli that surface area is huge that we don't see a decrease in resistance. So if you look at where is there increased resistance? One place. And that's where those bronchi get a little smaller. We see an increased resistance in this area, and then after that it drops because we have so many bronchioles. So the only place where we see a little bit of increased resistance is where we see that transition from cartilage to smooth muscle and a slight decrease in size. But after that, very low resistance. So the medium-sized bronchi is where we see a slight increase in resistance on our way moving air in from outside the body. So obviously, as resistance rises, it's harder to breathe. So what we do is we give people epinephrine to open up those airways if they're having a hard time breathing. People carry an EpiPen if they have a food allergy. Very, very important that they carry that EpiPen. What are some other things you can do? Let's say a person has asthma, they don't have the albuterol, they're kind of, surprised. Someone has a cat and you get in the car and on the way home, like my son went on a play date. He was fine when he was there, but when he came home, he started wheezing. It was kind of a delayed reaction, and we see that sometimes, that the allergy happens after the fact, right? Like if you've eaten food, maybe a couple hours later, if you have an allergy to that food, you start to react with hives or whatever. What's something you can give someone that helps dilate bronchioles? Do you know? You're at a restaurant. Cold air sometimes makes it worse. That's because you have inflamed airways, and that will decrease inflammation. But if you have like a reactive, sometimes that makes it worse. And I only know that because I dated a guy for quite a while who had really bad asthma. And when it was really cold and dry, he had a hard time breathing. Warm, moist air is actually better for asthma, yeah. But caffeine. Caffeine is a natural bronchodilator. So when this guy I was dating in college, if he was away from his asthma inhaler, he'd have a cup of coffee or a Mountain Dew, and that would help his asthma. So if you're in a pinch and you know someone who's struggling with a little bit of asthma, give them a little caffeine. That's a natural bronchodilator. Okay, surface tension, we already talked about that. That acts inward on the lung. And we know that surfactants produced by those type 2 alveolar cells reduces that surface tension. Deep breathing stimulates type 2 alveolar cells to produce surfactant. So when you have a patient that's lying around on lots of pain medications, really sleepy, in lots of pain, pain is not being covered and they're breathing really shallow, they're at risk for lung collapse because of increased surface tension, low surfactant production. So it's really important we medicate them sufficiently and then have them use that incentive spirometer. You don't say, here, use your incentive spirometer when they're rating a pain of 9 in their abdominal cavity or in their chest. That's unreasonable. You would say, here's some pain medication. I'm going to come back in 45 minutes and see how it worked, and then we're going to use your incentive spirometer at that time. You don't tell people to use it when they're at their peak of pain, right? That's just good nursing judgment. Babies that are born premature, their alveoli are not fully expanded, they don't have good surfactant production. Oftentimes we need to help ventilate them, and doing that to those tiny little baby airways damages alveoli, and they have what's called respiratory distress syndrome, and they can have that their entire lives. So a regular cold can be life-threatening to these babies that are born premature. Even though they overcome their prematurity and they're relatively normal-sized children and they're active in school, they get sick, they're in the hospital because they've got crappy lungs from being born premature. And that's why we get our flu shots, is to protect those kind of kids, because if we walk around with the flu and spread it to a kid like that, they could end up dying from that because of having bad lungs. It can't overcome fluid in the lungs and what influenza brings. So compliance we talked about, it's normally high because the lungs are distensible. Distensible means to stretch. We can stretch them outward. So we normally have good lung compliance because they can stretch out. They follow the ribs. And if we have low surface tension, that is going to increase compliance. Would you agree? Surface tension and compliance fight each other. Would you agree with that? And surfactant is kind of the mediator that helps compliance win over alveolar surface tension. So what is going to reduce compliance? If I have scar tissue, I have a fibrotic lung. Let's say I have lung cancer and I have tumor. Tumor is a solid mass of cells. Is that going to stretch? No. So that would have low compliance. If I have high surface tension, not enough surfactant, that's going to have low compliance because it's going to want to collapse inward. And if I have a stiff rib cage, this happens as we age. The cartilage of our ribs, between our sternum and our ribs, we've got cartilage there, the intercostal cartilages, those stiffen with age. So elderly people have less ability to inhale and exhale. So there's another example, they get influenza, they can't deep breathe as well because of a stiff rib cage, and they can't cough as well, because when we cough, we're compressing our chest cavity, aren't we? And really decreasing pressure rapidly to force junk out of our lungs. Well, if you're an elderly person, you have weak muscles and a stiff rib cage, you can't change your chest cavity rapidly, and you can't forcibly inhale, and you can't forcibly exhale. I mean, you hear old people cough, right? They're like, that's the best they can do because weak muscles and stiff ribs. So again, this is all decreasing lung compliance, a deformity of the thorax. Someone has a pigeon chest where their chest protrudes outward. Some people are born that way and they have to get that repaired later in childhood. That's something we see people on pediatrics for, is a repair of the pigeon chest. Stiffening of the costal cartilage, like I said, as we age. And then paralysis of the intercostal muscles. So anybody who has a neuromuscular disorder like Lou Gehrig's disease would have a hard time inhaling, contracting the diaphragm, bringing the ribs outward, right? Because those muscles aren't working. Same thing with muscular dystrophy. Those people can't control those muscles, so the muscles of breathing weaken, and that's what leads to their early death. Muscular dystrophy is an inherited disease. It's an X-linked disease passed from the mother. So it's what's most commonly seen in boys. We have a student, actually. Did you ever see him in the electronic wheelchair navigating around campus? He has muscular dystrophy. Dead space, we talked about this in lab, so we're not going to talk a whole lot more about that. Just remember, dead space is where there's no gas exchange. No gas exchange. So where would we see, what parts of our respiratory system are part of the dead space? Trachea, bronchi, bronchioles. Well, that's the dead space. What if I have emphysema? Do I have more dead space if I have emphysema? Do I have areas of my lung that can't participate in gas exchange? Just like my sponge, if I take that chunk of sponge out of my big sponge, do I have parts of the sponge that can't participate in soaking up water? No. Yeah. So if you have emphysema, you have a larger dead space. And that's why they struggle to get their air, and they need oxygen because there's no alveoli to take up that oxygen and put it in the blood. So we talked about the pulmonary function tests. We talked about the two types of diseases that we see. We talked about this in lab, so we're not going to talk about that again. So this will not be on the test. This is not on the test. This is all from lab, just a review. Now we'll talk about partial pressures. So before we do that, let's go over the answers to page 542. I want you to take a minute, and instead of me going through each one with you, I want you to, with a partner, go through 1 through 9, put the letters down, and we'll go over the answers together. Page 542 in your packet, on the bottom. All right, let's go through these. Number 1, the change in lung volume with a given change in transpulmonary pressure. D, lung compliance, good. Gas flow and changes inversely with this factor. A, essential for normal expiration. Expiration, that means you're exhaling, so the lungs need to deflate, right? So elasticity is a force that acts inward on our lungs. Number 4, leads to respiratory distress when surfactant is absent. B, diminished by age-related lung fibrosis and rigidity of the thoracic cage. D, loss is major pathology and emphysema. The lungs go outward with emphysema, right? So you lose that elasticity. Number C. And you would lose surface tension also, wouldn't you? B. So you could say C and B for that one. Because remember, people that have emphysema have to go to exhale, because they have to force their lungs to go inward to get that air out. It's like breathing through a straw. Try it next time you're drinking, pop to go. You can inhale okay, but exhaling, you start getting trapped air. Reflects a state of tension at the surface of a liquid. B, surface tension, dramatically increased by asthma. A, greatest in the medium-sized bronchi. A, very good. Okay, 3 was C, yes. So going back to our PowerPoint, I wanted to quick say something about this slide here. If we look at this slide, assuming everybody has the same amount of dead space, if we look at that and we just look at different respiratory rates, different volumes, so if normal breathing has this respiratory rate, this volume, yada yada, we get about a % effective ventilation of 70%. We want ideal ventilation, right? We want the maximum amount of ventilation for breathing. So if you have a patient who's struggling with their O2 sats, so the O2 sats are dropping because they're in pain, or they're getting up, or they're anxious, or they're short of breath, what type of breathing would you recommend to them if they want to get maximum ventilation over here? Slow, deep breathing. Yeah. And did we talk about how that wards off an anxiety attack too? If you're having in the middle of a test, or you're driving in your car and you're feeling really anxious, slow, deep breathing helps kind of switch from that sympathetic overdrive to parasympathetic. Okay, now we're going to talk about gas exchange in the body. So first of all, looking at the air is a mixture of gases, nitrogen, oxygen, carbon dioxide, and water. Not a whole lot of water, unless it's raining, right? But mostly oxygen is the biggest gas we see that our body uses compared to carbon dioxide, which is pretty small. So if we take these percentages and look at the partial pressure of total air, so 760 millimeters of mercury is air pressure at sea level, and we break that up based on percentages, so I take 0.46 of 760, I get 3.7. If I take 0.04 of 760, I get 0.3. If I take 21% of 760, I get 159. These are the partial pressures of these gases, okay? So in pure air outside, these are the partial pressures. So if we look at the gas inside the alveoli, it's slightly different from the gas outside the air. Even though we're breathing it in from the outside air, there's some changes that occur as we bring it in. And one is air is humidified. Bullet number 2, humidification of air. What do we have that lines our upper airways? Lots of mucus, and mucus is primarily water. And that's the job of mucus, is not only to trap debris, but to add some moisture to the air. So when you ventilate someone and you bypass those airways and you put a tracheostomy and you start just putting dry air in there, you can damage the airways. So people that are on a ventilator usually have a little bottle of water that air passes over to humidify that air. But when you're rescuing somebody, you know, you're not doing that, right? When you're using that bag, you're just pushing air in. We don't want to do that for very long because that would damage the airways. But we humidify the air with this mucus. So that's going to dilute the air a little bit. The oxygen content out in the air is 159 millimeters of mercury. When we look at it in the alveoli, it's slightly lower than that because it's diluted a little bit from this water vapor due to the mucus that lines our airways. So we're going to talk about external respiration, and this is on the first page of your packet. It has that nice diagram. And how we exchange the gases across the pulmonary capillary and the alveolar plasma membrane depends on the concentration of gases. So if I put someone on 6 liters of oxygen, would that push more oxygen from the alveoli to the blood versus room air alone? Yeah, if I increase the oxygen, I'm going to have more oxygen diffusing across that membrane. Higher concentration to lesser concentration. How well that lung is perfused, which means the blood flow going to those alveoli, so the pulmonary capillaries, the more blood I have flowing to those alveoli, would that increase the diffusion of gases across that membrane if I have good blood flow to that area? Makes sense, right? So perfusion just means blood flow to an area. And then structural characteristics of a membrane. If my membrane is full of water because I have pneumonia, if there's a lot of water on the alveolar side of the membrane, am I going to have good gas exchange? No. If I have a lot of mucus down in those airways, am I going to have good gas exchange? No. If I have blown alveoli, obviously not. Okay, so if we look at the partial pressure of oxygen in the veins versus the alveoli, there's a steep difference there. Where would we expect oxygen to be the highest if we look in the body? In your lungs, in the alveoli, right? So this is pretty much the highest point that PO2 is going to achieve in our body. We're going to bring it in from the outside. We're going to dilute it a little bit from 159 in the outside air to 104 in the lungs. But that's the highest, is in the alveoli. Isn't that what we want? Because we want it to diffuse from high to low. We want to get it out of the alveoli and get it to the blood. So it's always going to be highest there. And then it's going to go to the arteries. So here we can see it's 104, and this is on the first page of your packet I gave you. I gave you a blank diagram. So I would recommend filling some of this information in on the first page so you really get what's going on here. This is from your textbook, definitely. Yep. So we see highest O2 in the alveoli. We see lowest O2 where? In the tissue cells. Always less than 40 millimeters of mercury. So it's lowest in the tissue cells, highest in the alveoli. Guaranteed that's going to be on the test. Where is CO2 always going to be highest? We're making it in the tissue cells, so it's always going to be greater than 45 in the tissue cells, and it's going to be lowest in the alveoli, so we can diffuse it out. We always have this motion of diffusing CO2 out of the tissues, out of the pulmonary capillaries, and then exhaling it out of the out with our breath. Now, if we look at diffusion of oxygen, so oxygen diffuses to the alveoli. As it leaves the pulmonary veins going back to the heart, we lose a little oxygen because the alveoli, the cells of the alveoli, do they need oxygen to do their job, those simple squamous cells? Yeah. So we lose a little bit. We have 104, we only have 100 in the pulmonary veins because the lungs need some oxygen just to do their job. Then it goes back to the heart, and then it goes out of the heart, because remember now the heart supplies a little bit of oxygen or a little bit of blood over the surface via the coronary circulation, but we don't see a drop because that same blood continues on. So some of the blood is shared, but we don't, the whole blood doesn't pass through the coronary circulation, just a small portion. So this still has 100 millimeters of mercury. So then it's going to diffuse from 100 into the tissue cells, back and forth, until it's equal. So at the end of my capillary bed, the partial pressures of oxygen would be equal, which would be 40. So it starts out at 100 on the arterial side, but at the venular side, it's 40. And then it stops diffusing, and that 40 millimeters of mercury is sent back to the heart, goes to the lungs, and we exhale it out. Carbon dioxide, same thing. Carbon dioxide is highest in the tissues. It's going to diffuse out, right, until we get to what? 45. Once it's 45, then it leaves the heart. Diffusion stops, leaves the capillary, sorry, and then goes back to the heart and out. So we still have some oxygen in our veins, don't we? So we still have unloading possible. So even if we don't have good gas exchange, this blood is going to go up to the lungs and back through the circuit. So we do still have some oxygen if the body needs it, if we have higher demands. So we don't drop to zero after the capillary, or after we have the tissue capillaries, after we pass through the tissue capillaries. Okay. So we have a concept called ventilation-perfusion coupling. This is basically the blood flow is coupled to match the gases in the alveoli. So for gas exchange to be efficient, we want to make sure we have good blood flow to those parts of the lung. So what we find is the arterioles, the capillaries that feed the tissues, particularly the lungs, when we have high CO₂ in an alveoli, that will cause the arterioles feeding that part of the lungs to dilate. And wouldn't that make sense? If you have good airflow, if you have functional alveoli, wouldn't you want to maximize the blood flow to that area? Like if I have emphysema and I have blown out areas of the lung or damaged alveoli, would it make sense to dilate blood flow to those areas, to the crappy parts of the lung? No, that's going to cause a constriction in that area. So that way we maximize blood flow to the functional alveoli. So we call this concept ventilation-perfusion coupling. So the way I would remember this and study this is just memorize one of these two, because this is the opposite of this, right? And don't memorize this because that's too much. Let's just apply it. If the alveolar O2 is high, the arterioles dilate. The pulmonary, in the pulmonary capillaries, those arterioles that feed the pulmonary capillary. So just highlight this and just highlight this. Know an example of ventilation-perfusion coupling. And then if we look at, if we have high CO2, the bronchioles dilate. What is the job of the bronchioles? Is it blood flow or moving air? Moving air. Bronchioles, remember, is just moving air. So if I have high CO2 in my alveoli, don't I want to get that out of the body? Right? So that's why they dilate. So this influences, these chemicals, these gases, actually influence the vessels and the transporting pieces, the structures that they're in. So PO2 influences arterial diameter, PCO2 influences bronchial diameter. So both of those pieces are what we call ventilation-perfusion coupling. So CO2, high CO2 dilates bronchioles, high PO2 dilates arterioles. That's all you need to know for that, for the definition of ventilation-perfusion coupling. So this is just an example of that. Oops. Let me get this goofy thing out of the way. Okay. So pretty straightforward, just a visual of what we talked about. All right, so again, looking at that respiratory membrane, normally it's 0.5 to 1 micrometer thick. So very, very thin membrane. So we have rapid diffusion. But if I have lungs full of water and inflamed, like pneumonia, if someone has pneumonia, obviously that's too thick of a membrane, it's going to take longer to get across. Picture you're swimming across a small stream. Now I make that stream like a river. It's going to take a lot longer for that carbon dioxide and oxygen to exchange. And when you have emphysema, you don't have any alveoli to swim across, so that makes it harder for oxygen and carbon dioxide to exchange. So remember that internal respiration, so that's external respiration, what we just talked about. We just talked about what happens between the capillaries of the lung and the alveoli, things that can affect that. So we said PCO2 is going to do what? High PCO2 will what? Dilate the bronchioles, and high PO2 will dilate arterioles. That's external respiration, right? Remember in the beginning of our notes we talked about external respiration is what happened between the alveoli in the blood, and internal respiration was down between the capillaries and the tissues, that exchange. So now we know that PO2 in the tissues is always lower, right? Everybody agrees with that? So we see, because we're constantly sucking up in our cells, we're constantly sucking up oxygen, so it's always going to be lowest, because that's where we're using it. So again, going back to this, we're always using oxygen in the tissue, so this is this is internal respiration right here, correct? Did you label this on your diagram last time? And this is external respiration going on up here. So we talked about ventilation-perfusion coupling, that's going on here. So now we're down here talking about tissues and tissue exchange with the blood of PO2 and PCO2. PowerPoints, okay. So how does the blood transport these gases? Oxygen is transported mostly bound to hemoglobin. So iron is at the center of the hemoglobin molecule, so if we want to bind oxygen, we need to have iron as a part of that recipe. People with low iron are anemic, right? They don't bind oxygen, and as a result, they're fatigued. They're kind of washed out, they're pale in appearance. So this is what we measure when we put that little clip on your fingertip, right? We're measuring oxygen saturation on the lab exam. Some people got that very simple question wrong because it said name a normal hemoglobin saturation, and people wrote down a hemoglobin value rather than an O2 sat value. So we'll go over that in lab, and I'll be giving some points back. If you wrote a hemoglobin value, I'll give you that just because this is written kind of funny. But we call that an O2 sat. And those of you that work in healthcare, if you knew the question was O2 sat, bam, 95 to 100, right? Or over 90 is acceptable. So I'll be talking about that in lab this week. Anyway, so 98.5% is bound hemoglobin. So think of it this way. You're going to the lungs. It's like a school bus. Okay, the school bus goes up to the alveoli, loads up the bus with all these oxygen molecules, like kids on a school bus. So you load up the bus, and now the bus drives around the vascular system, right? So as the tissues need oxygen, we unload the bus a little bit, right? But hopefully you're constantly breathing, that you're always about 95%, right? So if we measure you with a finger probe, that you're going to be 95%. If you're breathing, you're constantly keeping your bus loaded. So if you stop breathing, you have a couple of minutes before all your tissue cells die, right? Because there's time to unload the bus to feed your tissues. You have a couple minutes before cell death occurs. And that's why CPR is so important, that we interact or intervene right away and not let people just sit there, and as their bus unloads, they die. So 98.5% of the oxygen is bound to hemoglobin. We have a little bit that doesn't get on the bus. It's just dissolved in our interstitial fluid, not interstitial fluid, extracellular fluid in the plasma. 1.5% is what's dissolved in the plasma. And this is what we measure as far as looking at an arterial blood gas. We're measuring this value. So arterial blood gases measure the 1.5%. And this is what our nervous system is constantly sampling to see, do we need to increase or decrease respiratory rate? They're looking at this value. So it's really, even though it's such a small amount, it's a very important amount, because this is what regulates our breathing, is this 1.5% dissolved in the plasma. And again, this is what is measured in the arterial blood gas. Because which is going to be used first, do you think? If you're exercising, oxygen levels are going down, you're not breathing well, we're going to use up this first, and then we're going to start unloading the school buses, unloading hemoglobin, okay? So if this is down, this is going to be down too over time. This is what we're going to measure, though. This is an indicator of poor oxygenation. So people that have lung disease, we're looking at their PO2, we're taking arterial blood gases. And remember, there's 4 oxygen molecules bound to 1 hemoglobin molecule. So we call something that is, we call hemoglobin that is bound to oxygen, we call it oxyhemoglobin. So when it binds oxygen, this thing is just in the way. There's this constant back and forth relationship of loading hemoglobin and releasing oxygen from hemoglobin. So what happens in the lungs? What direction, there's a double-sided arrow, what direction does the arrow point if we're talking about the lungs? To the right, because the lungs are going to bind oxygen, and the tissues is where we're going to be releasing oxygen, right? So the tissues goes to the left, the lungs go to the right. So the lungs are where binding of hemoglobin occurs, and the tissues is where releasing of oxygen from hemoglobin occurs. So what we find is that hemoglobin molecule changes its chemical affinity for oxygen as oxygen is binding. So that means if we have excess oxygen, because our tissue, we're relaxing, we're breathing well, we're not burning up a lot of O2, a lot of that oxygen is attracted to the hemoglobin molecule. So if hemoglobin binds 1, its affinity for binding more increases. Because we want to fill our hemoglobin molecule. That's the ideal, isn't it? And then if we tend to need oxygen because we're exercising now, or we're having a lung problem, we're not getting good ventilation, and we're dumping hemoglobin, once one hemoglobin leaves, the others leave. So think of it like the school bus. Kids want to be together. So as some kids get on the bus, the rest of the kids are attracted to getting on the bus. As the bus stops and some kids get off, the rest of the kids are attracted to getting off. And that's how hemoglobin works. So that makes it really efficient for making sure we're meeting the needs of the body. If we have excess oxygen, let's load it up. If we need oxygen, let's quickly get it off and supply our tissues. So the rate of this loading and unloading depends on oxygen levels. What would you think? If we have high PO2, are we going to load or unload? What? We have high PO2, we're going to load. It's going to be greater affinity for loading. If we have high temperature, what would you predict? Loading or unloading? High temperature. Your cells are working hard. Do they need oxygen when they're hot? Definitely. So we're going to see more unloading. Unloading. It's in the body. We have school buses running through the vascular system. It's hot. We're going to see unloading. We need oxygen to those hard-working cells. Temperature's up, body's working hard. So we're going to see more unloading with increased temperatures. And these are potential test questions, so I would write these down. I would put an arrow up equals unloading. Arrow down here equals unloading, right? Blood pH, if I'm acidotic, that's a hard one to predict. Acidotic, what causes acidosis? What? Hydrogen ions, working hard, acidosis, that would be unloading. So decreased pH, so a down arrow equals more unloading. PCO2 is increasing, means we're working hard, right? We're making a lot of CO2. Unload. Concentration of BPG, we didn't talk about this yet. That's later on in the notes. BPG, where are you? It's a byproduct of metabolism in red blood cells. So if it's increasing, so when this binds to hemoglobin, it increases its ability to release oxygen. So increased equals unloading. We're not going to talk a whole lot about that. Yes? Decreased PO2 is unloading. Increased PO2, loading. Yeah. Okay, so if we look at a curve of our PO2 and the oxygen saturation of hemoglobin, we see this kind of steep curve and then it flattens out a little bit. And what this means is that I see the PO2 in my blood and the oxygen saturation. If I come up here to about, let's see, 40. 40 is a PO2 in my veins. Would you agree with that? Isn't that the PO2 of the oxygen in the veins? Correct? So what we see as far as oxygen saturation, we start to unload oxygen as we get to lower PO2s. We see a steep unloading. But when I get up here to about 40, it kind of flattens. And the reason why that is because our saturation, if we look at percent saturation at 40, is about, what is that, 75%? 75% saturated at a PO2 of 40. Once we get less than that, we see a rapid unloading of oxygen from hemoglobin. Rapid unloading when we get to this PO2 of 40. Beyond that, it's a lot slower unloading of oxygen, and we are fully saturated. Here's 90. We're fully saturated at 60. At a PO2 of 60, we're fully saturated. So a PO2 of 60, we see we're fully saturated with oxygen. So only when we reach about that level of 60 do we see this major drop in unloading. So we steeply start dumping O2 from hemoglobin. And this is what we said, that when PO2 levels fall, we see a greater unbinding of oxygen from hemoglobin. When we get to a PO2 of 60, we're fully saturated. So it takes a little bit of a drop in our PO2 before we see rapid unloading. So let's look at this in a little bit more detail. So in our arteries, we have a PO2 of 100, and hemoglobin is 98% saturated. So if we increase our PO2, like by breathing deep breathing, that's not going to cause a lot more binding. So let's look up here. If my PO2 is 100, I'm fully saturated. So any more extra oxygen coming in, I'm fully saturated. So the goal is to fill the bus at a PO2 of 60. And is that a normal value? What should the PO2 be? Remember from memorizing your arterial blood gases? Do you remember what PO2 is supposed to be? Normal? Yeah, very good. 75 is the low value, the low end. So we're fully saturated at 60. So that gives us wiggle room to unload. So does the body want to sample, does the brain want to sample a PO2? If PO2 drops, we want to say, oh, start unloading. Or start, no, I'm sorry, not start unloading, start increasing the breathing rate. We don't really need to because we have these full buses of oxygen running through the vascular system ready to unload oxygen. So PO2 can drop to 60 and we're still fully saturated. We still have plenty of oxygen in the body to supply these tissues. So our PO2 level is not something that our body uses to increase the respiratory rate and the heart rate. We actually are going to look at oxygen levels next. Okay, so if I look at, that's just more of what we talked about. Okay, so we talked about this a little bit. One thing we can talk about real quick here is this curve. We have what we call left shift and right shift of the curve. So if we look at a typical curve, which is shown, let's see, which one is the, so at about 60 to 90, the 60 to 90 relationship, 60 to 90. So the pink one is our normal. Oh, there's an arrow showing that, okay. So this is normal. So what we call a left shift of this curve means that we have resting conditions going on. We're not exercising. It's a greater affinity for binding oxygen. A right shift means we need to unload hemoglobin faster. So a left shift means we're loading hemoglobin. A right shift means we're unloading hemoglobin. So a normal resting person, their hemoglobin saturation curve is right here in the middle. But if it shifts left to become steeper, that means we're loading oxygen. And if it's a right shift becoming a little more flattened, that favors unloading of hemoglobin. So exercise, seizures, poor respiratory rate, person on drugs, person with alcohol intoxication, person with a fever, anything that's going to cause the body to work harder to get oxygen is going to experience a right shift of this curve. A left shift is anything that favors binding, not using oxygen as much. Does that make sense? I mean, you can analyze this and get all freaked out about it and analyze the details and what do those temperatures mean and what is, oh my gosh. Just think, exercising, or a right shift means the body needs more oxygen, we're going to unload faster. Left shift, body does not need as much oxygen, we're going to bind more. That's all you need to know from that slide. Yes, yep, because this is just comparing temperature and this is comparing other factors like carbon dioxide. Okay, so again, anything that causes the body to work harder is going to cause more release of oxygen from hemoglobin. So there's a lot of slides here saying the same thing. It's just a lot of common sense if you just think of that. We're going to unload the bus when the body needs oxygen. What are some things that makes the body need oxygen? There's a term called the Bohr effect, which means if we have a low pH, which is an acidosis, that's going to release oxygen. So what are some things that cause low oxygen? Here's a whole list of things that can cause that, which would cause a right shift of our hemoglobin curve, right? Anything that decreases oxygen levels is going to cause a right shift. All right, so how do we transport carbon dioxide in the blood? Carbon dioxide is, some of it is bound to hemoglobin. You can see 20% is bound to hemoglobin. So hemoglobin is not just specific to oxygen, it also binds carbon dioxide. But most of carbon dioxide undergoes a reaction in the red blood cell to become bicarbonate ions. And we talked a little bit about this reaction in lab when we were studying bicarbonate ion and how it helps soak up excess acid. So you take carbon dioxide and water. So this is happening in the red blood cells. So highlight that so you know where this is occurring, this reaction. So carbon dioxide and water form carbonic acid. And that carbonic acid can then dissociate into ions, which are hydrogen ion and bicarbonate ion. This would contribute to acidity, right? But this would contribute to a base. So as long as I have equal numbers, I'm becoming neither acidic nor basic, right? Well, let's watch what happens now. The enzyme in charge of this is carbonic anhydrase. So over this arrow here is carbonic anhydrase. All right, so what happens then is in our capillaries, so we have these tissues that are working hard, right, building up CO2. Bicarbonate ion diffuses from the red blood cells into the plasma, and we see a shift occur. Remember that there's more chloride ion outside the cell compared to inside the cell? Remember we've talked about that? That's just an ion that's in higher concentration. So what we find is when bicarbonate ion leaves the red blood cell, it's a loss of a negative ion. that attracts any negative ions outside the cell to come into that red blood cell. So we call this the chloride shift. When we lose bicarbonate ion and we gain the chloride ion from the outside, it's called the chloride shift. So I'll highlight that term right there. It's just losing a bicarbonate ion from the red blood cell and exchanging it with a chloride ion from outside the red blood cell. So here's how it happens. So we have this carbon dioxide in my tissue cell. I'm exercising, walking on the treadmill, and diffuses into interstitial fluid. It's in less concentration in my capillary, my tissue capillary, so it diffuses into my tissue capillary, diffuses into, some stays dissolved in the plasma, that's the pCO2, and some enters the red blood cell. So it enters the red blood cell, that's where this enzyme is found, this carbonic anhydrase, and that is going to convert that to carbonic acid, which will dissociate into bicarbonate ion and hydrogen ion. The bicarbonate ion diffuses out of the red blood cell and pulls in a chloride ion at the same time. And again, we call this the chloride shift. It's this exchange of bicarbonate ion and chloride ion from the red blood cell. And this relationship, this releasing a hydrogen ion, that binds to hemoglobin, which actually influences the binding of oxygen to hemoglobin. I'm not going to go into the detail of that, but let's just, because we're focusing on carbon dioxide right now, so let's just focus on a majority of carbon dioxide that's produced here. It's going to enter the blood, and it's going to go right into the red blood cell and be kicked out as bicarbonate ion. So where is it at the end of this reaction? Where is the bicarbonate ion? Where is it? Yeah, it's in the plasma. It's out here, right? So it's not, this reaction, turning it into bicarbonate ion, happens inside the red blood cell with the help of carbonic anhydrase. Then it's kicked out. And for every bicarbonate ion we produce, what do we have to suck into the red blood cell? Chloride ion. What do we call that again? Chloride shift, okay? We also see this happening in the digestive tract. We didn't talk about it this semester, but same thing. So, so then now we have some of this, though, some of this carbon dioxide just stays dissolved in the plasma. What percent? Let's just label that. Let's just, what percent? 7 to 10%. 7 to 10% is here. So you can label this one, 7 to 10% is here. And then going back up, what percent is bound to hemoglobin? 20%. So let's go down there and find that one. Where is that one? Right here. 20%. 20% does this. Just goes right in, binds to hemoglobin. And then the other 70% is here, out in the plasma. Okay, so label this one 70%, out here in the plasma. Everybody okay with that? So this is a nice diagram. It just shows visually the 3 ways that carbon dioxide is transported. So which one is the body sensitive to that we're going to be measuring to see if we need to increase or decrease respiratory rate? Yes, the pCO2. And what is the normal value for this? Do you remember that from lab? Very good, 35 to 45. So the pCO2 is 35 to 45, and this is what is very delicately monitored by the nervous system to see if we need to increase or decrease the respiratory rate. All right, so we talked about this. And then this is how we pick it up in the lungs. So now we're in the lungs. This chloride dissolved in the plasma is going to enter the red blood cell. Chloride is kicked out again. So just think of that as whenever bicarbonate comes in, it bullies chloride the other direction, right? So chloride is kicked out, so we never lose chloride. We're not just constantly sucking chloride. The opposite reaction occurs up here in the lungs. So bicarbonate ion in the lungs enters the red blood cell, it becomes CO2 again, it diffuses out of the red blood cell into the alveoli, we exhale it as CO2 gas. Isn't that cool? I think it's kind of neat. Same thing, we see a greater affinity for hemoglobin to release carbon dioxide. It's exhaled out. CO2 that's dissolved in the plasma enters into the alveolar air and it's exhaled out. So it's just the opposite that occurs here in the lungs. So chloride is being kicked out of the red blood cell in the lungs, but it's entering the red blood cell out in the tissue capillary. So there's two diagrams. Just pay attention to where you're at. This one's in the tissues, so maybe underline this one so you draw your attention. This is in the tissues, and this is in the lungs. And this is the alveoli here that you're looking at. Maybe, circle that so you pay attention that you're in the alveoli. Okay, there's something called the Haldane Effect, that the amount of carbon dioxide being transported by the blood is affected by the PO2, because aren't they closely related? So if I have a low PO2 and a low oxygen saturation, I can bind more carbon dioxide to hemoglobin, because obviously if I have low oxygen, it's probably because something's going on in the body, right? I'm not able to keep up with the demands of the body. So that means carbon dioxide is building up as well. Aren't they inversely related? If oxygen levels are going down, wouldn't carbon dioxide levels be going up if there's some kind of respiratory issue? Or even if there's some type of extra activity going on in the body? So that makes sure that we're able to take care of the carbon dioxide that's building up, because we know excess carbon dioxide makes that carbonic acid, and it releases hydrogen ion if we have too much of it building up. So as a result, we become acidic. Remember, CO2 makes acid? Okay, so we talked about acidic conditions causes oxygen to be released. That's the Bohr effect. And the Haldane effect just says, as my buses unload, the buses load with carbon dioxide. So as I release the oxygen from hemoglobin, I'm binding more carbon dioxide to hemoglobin. And that's the Haldane effect. So Bohr effect is talking about acidity. Haldane effect is releasing oxygen. And you know what I'm going to do, and I'm a crazy person because I'm doing this all the time this semester, driving myself nuts, but I'm going to make a crossword puzzle for this, because there's so many terms that you need to know for this respiratory test. And those of you that had me for general, we did crosswords with Embry, and you guys like those. I'll make a crossword and put it out on Blackboard to get you familiar with definitions, and I can see that being helpful with Bohr effect, Haldane effect, and all this other stuff. Okay, so we already talked about that CO2 makes acid, and this bicarbonate ion that's released to the plasma is available to soak up excess hydrogen ion. So if we go back up, let's see, here in the tissue, so we have this bicarbonate ion floating around in the plasma. That's available to soak up excess hydrogen ion. So this is a buffer. This is part of the buffer, one of the buffer systems that we're going to talk about in lab next week, to soak up excess hydrogen ion. Okay, so that's here. So if I have excess hydrogen ion building up in the blood, bicarbonate ion can attach to it, bind to it to form H2CO3. And as long as that hydrogen ion isn't free and off by itself, acidity goes up. Like, how should I say it? pH goes up, acidity goes down. So pH goes up, as long as I can remove that hydrogen ion from being a free ion causing trouble. If I bind it up as as carbonic acid, it's not contributing to acidity. But if the pH, the blood pH, is starting to rise too high above, what is the pH of blood? 7.35 to 0.45. So if it goes too high, bicarbonate or carbonic acid can dissociate and release hydrogen ion to bring that pH down again. So this carbonic acid can either, and remember, let's go back to this reaction here, it's reversible, right? So I can bind up excess hydrogen ion and form carbonic acid, or I can dissociate and release bicarbonate ion and hydrogen ion. depending on the... Correct. If we... pH will go up if we have a basic condition, like 7.4, anything over 7.45 we call alkalosis, anything less than 7.35 we call that acidosis, right? Yeah, I know, it's, yeah, increasing acidity is actually a low pH, right? Okay. Okay, so back to, okay, so obviously we talked about hyperventilating causes CO2 to accumulate, and CO2 makes acid, so that's going to cause pH to go down, right? So we want to slow the breathing rate down. But if the body needs to adjust the pH, the body can do that just by affecting the respiratory rate. So if someone has an acidosis condition, do they want to increase or decrease to get rid of that? Let's say it's due to CO2. So CO2 is building up in the blood, causing pH to go down. How can the body respond? How can the lungs respond to get rid of that CO2? Increase the respiratory rate. So when you see someone coming into the ER and they're that's a sign of acidosis. The respiratory system is trying to get rid of acid through CO2. Now that might not be the cause of their acidic condition. It might be lactic acidosis because they're in diabetic ketoacidosis and they're releasing all these ketones. I said lactic acidosis, I didn't mean that. Ketoacidosis. So the body can't use sugar, so it's burning fatty acids and proteins, and they've got this ketoacidosis going on. Blood pH is down. The respiratory system senses the pH and starts increasing the respiratory rate to bring the pH down. So that can help. That's called a compensation by the lungs, but it's not going to fix the problem because the problem has to do with metabolism and the lack of sugar in the cells. So they're burning fatty acids and protein for energy. So how do we control our respiration? Well, there's two parts. So we have the dorsal respiratory group that has information about stretch receptors and chemoreceptors. The chemoreceptors are going to be picking up PO2 and PCO2 information and pH. So where do we find these? The dorsal respiratory group is found in the medulla, and the ventral respiratory group is found in the medulla, and then the pons influences that. And how does it influence? These neurons feed the two respiratory muscles, the diaphragm and the external intercostal muscles. So when you want to increase the respiratory rate, we're going to see an increase in action potentials going to the respiratory muscles. Because remember, in order to drive air movement, we need to change the volume of the thorax. So it's a very simple process of just firing action potentials in these two major breathing muscles. All right, so the pons influences the medulla. So it smooths the transition. When we inhale and exhale, it's kind of a smooth pattern, inhale, exhale, stimulating the muscles and inhibiting the muscles. Stimulating the muscles, inhibiting the muscles. When are we stimulating? During what phase of the breathing cycle are we stimulating the muscles? Inspiration. And then we inhibit those muscles during expiration. So expiration is a passive process. We just rely on the elasticity and surface tension of the lungs to just deflate those lungs and drive that air out. Okay, so here we can see a little bit the response. So if I have an increase in carbon dioxide levels, that causes a decrease in pH because we know that that makes more acid. So as a result of that, we have chemoreceptors in the medulla that respond to that excess PCO2 or the excess pH or the low pH due to the excess PCO2. And that causes an action potential to the respiratory centers, stimulates the respiratory muscles, we increase ventilation, we get rid of the CO2, and all is right with the world. That's a negative feedback mechanism, right? We see increasing carbon dioxide levels in the blood, and as a result of the body kicking in, we have a decreased carbon dioxide level in the blood. So we have chemoreceptors also in the carotid and aortic bodies. So in those arteries, they also have chemoreceptors that are responding to PCO2 and pH. But most of it is occurring in the medulla. So the number one key take-home point from this flow chart, I'm not going to ask you details on this flow chart other than what is the number one chemical driving breathing. What is the number one chemical driving breathing? PCO2. PCO2. That dissolved carbon dioxide in our plasma. Arterial PCO2 is what we care about. So how deep we breathe, how fast we breathe, all of that is affected by our PCO2. So obviously if we're breathing too fast, that's going to cause CO2 levels to decline because we're blowing it out. We're blowing this CO2 out too fast. And that causes what? Acidosis or alkalosis? Alkalosis. pH is starting to go up. And the brain, when we have alkalosis, causes vasoconstriction. And if we constrict the vessels feeding the brain tissue doesn't get its oxygen and people will pass out with hyperventilation. And you see that when people get really bad news, somebody died in an accident, some horrific thing happened, people start to hyperventilate and they pass out. And that's because of becoming alkalotic. And then as they're passed out, the body kicks in again and they don't have the mental stimulation, the emotional response causing the breathing, then their breathing returns to normal and then they'll come to. So apnea, we know that PNEA talks about respiratory rate. So tachypnea, what does that mean? Breathing too fast. Bradypnea, breathing too slow. Apnea, A means, like asystole meant no contraction. Apnea means no breathing. Okay, so we talked about chemical factors. We do see these chemoreceptors in the aortic and carotid arteries kicking in when PO2 gets less than 60. Why does it have to be less than 60 for these things to kick in? Very good, very good. If we look at our hemoglobin saturation curve, when we get less than 60, let's go to our normal one. When we get to 60, that's where we see a real steep drop. So we're pretty fully saturated. Oops, sorry, I'm supposed to be over here. Here's 60 PO2. We're fully saturated at 60. So any drops from 60 to 100, we'll just unload some oxygen, right, from the hemoglobin. But once we get less than 60, we better hurry up and quickly unload that hemoglobin because we're fully saturated at higher than 60. So we don't have to worry about kicking in with lower oxygen levels because we have saturated hemoglobin to kind of take care of business for us. Okay, so going back. Okay. So we don't have to worry. We're not going to see a big change until we get less than 60. So that's a key concept for this slide. Less than 60, now we're going to kick in increased ventilation. So we don't see an increased ventilation until the PO2 is less than 60. So here's those carotid bodies, aortic bodies. So we see this is where the nervous system interacts to pick up what's going on in the blood to affect breathing. So carotid body and aortic. So these are the carotid arteries, right? This is the aortic arch. So that's where those are located. Carotid body and aortic body are in the aortic arch and the carotid arteries. So again, things that can cause pH to decrease would be holding on to CO2 because we're not breathing. So what are some things that cause CO2 retention? Drugs, alcohol, anesthesia, right? Those are all things that are going to cause CO2 to be retained. And also bad lungs, right? Emphysema asthma, anything that's going to prevent air from flowing, choking, that's going to cause CO2 to be retained if we're not breathing fast enough or we have a blockage. So low respiratory rate or some kind of blockage is going to cause that. Accumulation of lactic acid, what would cause that to build up in the body? Intense exercise. Seizures is an example of intense exercise, right? Because the muscles are all contracting. That's why we need to stop seizures. We can't let them go on for minutes because it's very dangerous. And ketone bodies for people with diabetes. They're breaking down all that fat, converting that into ketone bodies, keto acids. So we're going to see that as a factor as well. So the respiratory system will try to raise the pH by increasing the respiratory rate and depth. We call this, there's a special name, it's called Kussmaul's breathing, Kussmaul', Kussmaul's breathing. It's called increased respiratory rate and depth. So if someone has low pH, has any of these conditions listed here, we're going to see them breathing like this. It's rapid, but it's deep, isn't it? And that's Kussmaul's breathing. And I've seen it. I've seen it in patients. I've seen it in kids that have DKA. So look for that. You can say, something's wrong there. I saw it in someone who was dying that had a necrotic bowel. It was a teenager who had a major brain injury. His bowel had died. He had huge infection, sepsis, which causes acidotic conditions. And he was doing that kind of breathing because he was in a coma, he was out, and he was breathing like that. Something that's a classic sign of acidosis, and the body's trying to compensate. So we need to get in there and figure out what's going on and how can we fix that, because the body's fighting to do it. We have to correct the problem. All right, so anyway, key thing, underline, highlight, write it on your forehead backwards so you can read it in the mirror for the next week. This is key concept. And this is important because when we look at our patients, if they have CO2 levels that are off, we're going to see a change in the breathing rate, more than PO2. So again, we only see PO2 affecting it when what? When that level is what? Drops below 60. Good. And that's what we see here. And it's through these chemoreceptors that pick it up, right? Chemoreceptors are picking up the CO2 and the O2 levels. Now the hypothalamus and the limbic system can also modify the rate and depth of breathing. So if we have pain, anger, emotional responses, that's the limbic system overcoming, the normal respiratory rate. We know the body temperature, we already talked about that. And if we want to hold our breath, we can. The cortex, the cerebral cortex, the thinking part of our brain, can override all these controls, and we can stop breathing that way. So a child that doesn't get what they want, sometimes they hold their breath, right? And they pass out. I had my daughter, she's 13 now. When she was 3 and younger, like 1 to 3, if she would cry, like she hurt herself or something bad happened, she would cry. You know how kids cry and they like exhale, 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 and then they go like that after the in between cries? Well, she wouldn't do the she would cry all her air out, then her lips would turn blue, and then she would pass out. And her eyes would go black. And the first time it happened, I was freaking out. I thought she's having a seizure, she's dying, because her arms would kind of curl while she was laying there. And it was terrible. She did it about 4 times in her childhood. It was just terrible. And one was really embarrassing. We were out in the driveway. I was at home. I was an at-home mom, and she was in her little Tykes coupe car, the little yellow and red car, and she's in there, and she's looking at me, and she's about 2. And I said, don't you go on the road, because we lived on kind of a fast road. I said, don't go on the road. And she looked at me like, oh, yeah? So she scooted closer to the road. I said, don't you go on the road. You're going to get a bare butt spanking. Because I always threaten that, for the big stuff, for the big dangerous stuff. So she looks at me again, and pretty soon scoots right into the road. I'm like, you little stinker. So I pulled her out of there, smacked her on the butt. She cries in this horrible cry, and then passes out on the sidewalk. And I thought, this looks really good to the neighbors. Beating my child to the point of knocking them out, So I'm like, oh my gosh, I picked her up, scooped her up, and brought her in the house. It was terrible. And then she was running one time. It was 3 in the morning. We were driving to Florida. She was running across a wayside gas station. They had these huge, really neat gas stations in somewhere. Anyway, between here and Florida, yeah. And she was running across, it's 3 in the morning, she falls and trips and then passes out. So she's laying there. I come out of the bathroom, my husband's picking her up and she's just this limp body laying in the wayside of the gas station. I'm like, oh my gosh, he picks her up into the car and puts her in the car seat, and it was terrible, it was really stressful. But she only did it a couple times, because once we knew she was starting to do that, we're like, it's okay, breathe. So it was, anyway, scary. No, the doctor said it's when kids are really young and they can't express themselves. Crying is like a major emotional response, and they just get so upset that they run out of air. It was really weird. Yeah, really strange. All right, so how much do we have left here? Okay, I'm just going to finish because we have a minute left here. So we know that if the airways come in contact with particles that are foreign, it's going to cause your airways to constrict, right? Like smoke inhalation, that causes constriction of the airways. It's not full of oxygen. Smoke, displaces oxygen in the air that we breathe. So people who are, in a house where there's a lot of smoke due to a fire, they die of smoke inhalation because of inflamed airways. And we know that if we have, something that is in the air, it causes us to cough, causes you to sneeze. Like you might find that you sneeze and the person next to you sneezes, right? Probably because the same irritant that was in the air stimulated both of you to sneeze. So we have these reflexes to protect our airways. And some of these, this is just a kind of a summary of the different influences on the pons and the medulla for changing breathing. So if there's an irritant, that's going to cause us to respond coughing, sneezing, stretch receptors in the lungs. If we get overstretched, like you're running in a race and you're getting to the end and you're just exhausted, your lungs will reflexively deflate, because we don't want to overinflate our lungs. So that's going to inhibit breathing. So when our lungs become overly stretched, breathing is inhibited to cause them to deflate so we don't damage. Anything on the left side here is going to stimulate breathing. So when you're moving, like if you're just going up the steps, like I like to try to take the steps, and no matter what kind of shape you're in, you're going to deep breathe when you're going up the steps. You're going to be sucking wind because you're moving, just moving your muscles like this. Your respiratory system says, oh, we got a lot of movement going on because of these receptors in the muscles and joints, those proprioceptors. As we're moving them, it causes increased breathing. Even though we don't need the oxygen, we could just be doing this, it's going to cause increased breathing because of that input into the nervous system. And again, we talked about the chemoreceptors in the carotid arch and the aortic arch, and then the emotional stuff that happens at a higher level at the hypothalamus. All of these are influences that either increase breathing or decrease breathing. And this is just talking about diseases of the lung. We're not going to talk any more detail about that. So that concludes the respiratory system.